This is Endocrine Feedback Loop. I am your host, Chase Hendrickson, and welcome you to this Journal Club podcast series brought to you by the Endocrine Society. Thanks for joining us as we explore an important article recently published in one of the Society's clinical journals. Hello and welcome back to the Endocrine Feedback Loop podcast for our 45th episode. For this episode of the podcast, we return to the JCENM, this time to look at a study reporting the long-term effects of anti-obesity medications. The prescribing of such medications is increasing rapidly, though we know relatively little about their effectiveness in maintaining weight loss after that initial year or two. Such knowledge will help us as prescribing clinicians in addition to informing policymakers and payers. As is typical for us on this podcast, the investigators here use an observational study design, so that will require careful thought. By way of reminder, I host the Endocrine Feedback Loop, but spend most of my time working at the Vanderbilt University Medical Center in Nashville, Tennessee, as a general endocrinologist and medical director. With us today for the first time as our regular contributor is Andrew Crafton from the University of Michigan in Ann Arbor. He focuses his clinical care and research on obesity, serving as a director for the Weight Navigation Program and the Post-Bariatric Endocrinology Clinic, as well as an assistant director for the Weight Management Program at Michigan. Importantly, for this podcast, he is an expert educator working as an associate director for their endocrinology fellowship program. Joining us today in our virtual recording studio as our guest expert is Jamie Almondos from the University of Texas Southwestern in Dallas. He, like Andrew, is an expert in obesity care with his clinical and research interest focused on interdisciplinary programs for weight management, post-bariatric surgery, weight recurrence, and disparities in obesity care. Both Andrew and Jamie are well published in obesity medicine, and as you can tell, a perfect pair of endocrinologists to join me in helping us to understand this paper. As always, everything we say will be our opinions only and not those of the Endocrine Society or of our respective institutions. Today, we review 5-year weight loss maintenance with obesity pharmacotherapy, which was published by the Journal of Clinical Endocrinology and Metabolism in September 2023. Michael Weintraub from Weill Cornell in New York served as the first author of this paper. Now I will hand the discussion off to Andrew to lead us through the introduction of the paper. He will highlight the main points that the authors make and get Jamie to give us important background information. Andrew?
2023 was certainly an exceptional year for obesity medicine, and I know that the lion's share of that attention has been devoted to the use of nutrient-stimulated hormones such as semaglutide and tirzepatide. Now, despite these promising results, we know that these treatments aren't the panacea for obesity, and given the economic and practical challenges surrounding their usage, this paper provides important contributions to the medical management discussion, particularly use of anti-obesity medications as a whole. So the paper sets the stage for the importance of this discussion by highlighting the prevalence and consequences of obesity. So if I were giving a classic PowerPoint talk, this is where I'd be whipping out that CDC map of the US and showing the obesity prevalence, but fortunately, our listening audience is spared from this, and I'll summarize by saying obesity is a disease that has myriad metabolic consequences and affects over 40% of the US adult population. So I'd love to have Jamie give a high-level overview of the pathophysiology of obesity.
Thanks so much for the introduction, Andrew and Chase. I really wish I could show everyone the heat map. I don't want anyone to feel cheated on the podcast today. Obesity, it's such a chronic and complex disease process that unfortunately gets reduced down to like a simple thermodynamic equation by many people in society, including healthcare providers. Calories in, calories out. I think we need to kind of take a few steps back and acknowledge that obesity results from a chronic positive energy imbalance, which ultimately leads to expanded adipose accumulation within subcutaneous, visceral, ectopic, and other areas. It can include liver, muscle, and around the heart, for example, that has both direct and indirect actions in the body. So, for example, there can be biomechanical effects in terms of things like osteoarthritis, obstructive sleep apnea. There can be cardiometabolic effects in terms of lipotoxicity leading to insulin resistance and endothelial dysfunction. But I think also importantly, we need to focus in on things like psychosocial impacts, particularly with respect to potential impacts on mental health, experience stigma, and weight bias.
As you know, treatments for obesity have been continually developed over the many, many years. And many things have been tried in the absence of good evidence foundation, but gradually over time, we've built out more and more information from studies such as Look Ahead and the Diabetes Prevention Program, just to name a few. And they provide us with some valuable treatment information. Now, this paper asserts that yes, evidence-based lifestyle interventions can facilitate clinically meaningful degrees of weight loss. However, these efforts are difficult to sustain and weight regain is common. So, Jamie, can you describe how some of your patients experience this reality?
So many people who live with chronic obesity will come to the office dreading their weight management specialist telling them to consider eating less and moving more. I think many people have been through a variety of different, likely unsuccessful attempts at managing obesity through a series of both restrictive and also kind of calorie burning efforts that result in a weight reduced state that is associated with a variety of different neurohormonal adaptations. We call that metabolic adaptation to obesity, where there are changes in everything from thyroid hormone, sympathetic nervous system function, skeletal muscle efficiency that really promote weight regain or weight recurrence if we look at this as a kind of chronic disease type model. And I think the challenge is that many healthcare providers and people in society will frame this weight recurrence as a failing on the part of the patient in terms of consistency, in terms of willpower. And I think this creates a very toxic narrative that makes both the kind of engagement of the patient with the healthcare provider and with healthy behaviors something which becomes very adversarial and challenging. And what we need to do is kind of clear up that narrative, discuss the science that we know about obesity to make sure we empower people to treat their obesity effectively with all the tools we have available, because we know that as much as healthy dietary patterns and physical activity are foundational for health, they're not terribly effective for treating obesity for the vast majority of people.
What you're describing is a chronic disease that's challenging to control with lifestyle and behavioral approaches alone. And as such, it's really unsurprising, right, that we've had to utilize our understanding of the pathophysiology of the disease to create pharmacotherapeutic options to manage the disease. And so we know that this adjunctive treatment with anti-obesity medications can increase efficacy and sustainability of these lifestyle efforts. But historically, despite this information, these AOMs, as we call them in the biz, have been infrequently used. And what do you think are some of the barriers to prescription of these medications that are available?
I think there are a lot of different ways you can look at this. Some of the literature has looked at utilization of anti-obesity medications in eligible populations in the US. Some studies would suggest that it's less than 3% of those eligible for anti-obesity medications receive a prescription. And of those, very few of them will get treatment beyond 3 to 6 months. I think what we need to do is look at the challenges with prescribing. And so on the prescribing end, that's down to kind of healthcare providers and their interactions with the patients, because that's where the prescription comes from. And I think it comes down to educating prescribers that anti-obesity medications are safe and effective, that they are great adjuncts to lifestyle modification. We should not use kind of this failure-based algorithm of, well, let's try these 5 different diets and exercise programs, and if those don't work, then maybe we'll consider a treatment. We wouldn't do that with hypertension or hyperlipidemia, yet for some reason it's acceptable in healthcare practice still to look at obesity in a very different light. I think once a prescription is written, there are a host of issues on the patient side in order to get that. That includes insurance coverage, cost affordability, and then quite famously as well, unfortunately, supply chain issues with anti-obesity medications over the last year. So I think there are a lot of barriers, and what it comes down to from the prescribing end is making sure that we empower our healthcare colleagues to learn about obesity as a chronic disease, and that these treatments that are emerging, in addition to the older therapies, which are kind of most cited in this paper, are safe and effective for helping people to achieve clinically meaningful weight reduction.
Another point that this paper makes in the introduction is that, as endocrinologists, we're certainly used to adding more treatments as necessary to control things like diabetes and hypertension and dyslipidemia. And yet the clinical studies and treatment guidelines for obesity are, and I'll editorialize and say, frustratingly unique when compared to other chronic metabolic diseases. And so, unlike therapeutic practices for those other diseases, obesity-related pharmacotherapy on-label use is limited to 2 or fewer medications. The other issue that they take with the current evidence that we have is that many anti-obesity medication clinical trials have been limited to fewer than 2 years in duration, which is, of course, a relatively short duration in the context of a chronic disease. So, Jamie, could you comment on the current state of guidelines and sort of contextualize these realities as we're talking about them?
Again, I think the reality highlights how differently we view obesity as a disease relative to other conditions. I think we need to acknowledge that, clinical trials are difficult and expensive for pharmaceutical companies to do over the long term. And so what we have is limited data, and what we can do, or the best that we can do in many circumstances, is look at studies like this where we're gathering and perhaps pooling clinical experiences of multiple centers to look at both the effectiveness and safety of these agents. What we do know, at least in the short to medium term, is that these agents are safe and effective. I think what's challenging is knowing on individual level what is the best way to combine therapies to see the best effect. I think the important thing to know is that when we treat obesity, our goal is not a specific weight or a weight number. Our goal is health. Our goal should be quality of life. Our goal is not getting everybody who we treat with an anti-obesity medication to a BMI of less than 25. Our goal should be individualized. And I think it's important to have these patient-centered goals, have these patient-centered discussions, and then to choose therapies in conjunction with the patient that align with the greatest likelihood of achieving those goals and also helping with other comorbidities or complications related to their obesity.
If we think about just following the strict guidelines, every patient with obesity that we're considering medications for utilization would be using, one medicine at a time. And the argument of this paper is that, this is going to be a real world look at, yes, an academic weight management center, but this is how people actually do things. And we utilize multiple medications, try different combinations, and utilize off-label combos of these medicines. And so is that a correct assertion? Does what they're describing resonate with what you're seeing in real life?
Absolutely. Real life obesity medicine practice is kind of a daily trial and error, I think, for many patients, knowing that there's huge amounts of variability seen with any weight loss intervention, be it lifestyle, be it pharmacotherapy, be it bariatric surgery. And especially when we're using non-incretin based or non-nutrient stimulated medications, which may be less effective for weight reduction, we often have to combine them in order to see clinically meaningful weight loss. That could be a whole nother podcast in itself of what is clinically meaningful weight loss or weight reduction. But suffice to say, if we're talking about improving numbers, improving kind of hard disease outcomes, be it activity scores on liver biopsies for fatty liver, for example, typically we're talking about kind of 10% weight reduction or more. Many people cite kind of 15% as this kind of pay line that we're shooting for. When we look at the phase 3 clinical trial data for most of these kind of older anti-obesity medications, naltrexone, bupropion, or phentermine, topiramate, we're really talking kind of a 5 to 10% average weight reduction. That's average. So to get to that 10% or greater, we're really talking about how we can combine these for better effectiveness. Everyone's different in terms of tolerability, in terms of effect as well. So having to use medications which are on label for weight reduction, but both using medications that are also off-label for weight reduction, it's also one of these arts to kind of modern obesity medicine practice. And those of us who are endocrinologists will be very familiar with using things such as metformin, for example, to help our patients with a variety of health issues, including for weight reduction and diabetes prevention.
So I'll conclude the discussion of the introduction by quoting from the paper the focus of the study, and it's as stated in this retrospective observational study of patients with medically managed obesity. We examine long-term weight loss associated with anti-obesity pharmacotherapy over 2.5 to 5.5 years.
All right. Thank you, Andrew and Jamie, for that wonderful overview. I think we have a good understanding now, a shared understanding of many of the challenges that go with obesity management and the current state of what we know works and doesn't work. So with that, I think we know why we need so much more information. And as Andrew just walked us through with what the authors are hoping to show here, gives us some insight into how this could help move forward our clinical practice. So the methods here, the way that I would encourage us to think about these, I don't know that the authors use any classic study design that clearly fits into an obvious description. They do a couple of different things. This is an observational study, as we talked about earlier. And I think part of it, the initial data that we'll look at, the results that Andrew will walk us through here in just a second, think of it as a case series. It's really just a description of we had a whole bunch of patients, we treated them in different ways, but compared as or describing it as a group, this is what happened to them. And that's really more of a case series. However, they then subdivide those folks, and it's not a classic retrospective cohort study, but you could almost think of it that way because they split these folks into a variety of different groups based on their exposures and then look at those exposures to see, well, what's the difference in the outcome? And in the outcome, we'll look at the details, but it's related to how much weight did they lose, how much weight did they keep on. And sometimes the exposures are what we would maybe more naturally think of as an exposure, meaning something like a comorbidity. So we'll look at a little bit of data around other endocrine comorbidities, whether they have thyroid disease, whether they have PCOS. But the real important thing that we'll think about here is thinking about exposure based on what type of medication they were exposed to. We don't often think of it that way, particularly if it's a medication, because we're used to that in a clinical trial being much more intentional. But here, since this was observational, we would think of this as an exposure since different individuals were exposed differently here. Okay, so back to this study, the inclusion criteria. So they were looking at only adults, so that's individuals aged 18 to 75, and they had to attend an initial visit at a tertiary academic weight management center between April 2014 and April 2016. And importantly, they had to follow up for 6 months or more. Several exclusion criteria that we need to walk through because they have several important implications here is one. So if your BMI was under 25, you were excluded. If you were not prescribed a medication or maybe were prescribed it, never took it, that was an exclusion as well. If you were pregnant at that initial visit or became pregnant during the study period, also excluded for that reason. If you had had a history of bariatric surgery within a year of that initial visit or ended up having surgery during the study period, also exclusion criteria there. A really important one here is that you had follow-up less than 2.5 years. We'll come back to that in just a second. If in that follow-up, if you had a gap between visits that was more than 2 years, that was also an exclusion. And a couple of things I want us to think about here. We'll come to this in the discussion, but I'll say I think the authors do a very good job of wrestling with their limitations. They do it in their discussion, but they really think carefully about the limitations that are intrinsic to observational study designs. We'll talk about them here because I think it fits a little bit naturally, even if the authors don't. But part of them is thinking about their population. I don't know that this would truly be a referral bias, but it's helpful to think about it this way, is that this is a subspecialty center. And so they may be getting a unique subset of patients that come to see them. Additionally, it goes along with this, it's a little bit differently, but exactly what they do here may be different than other centers. We're going to come back to that more in a second. Another one is thinking about the idea that to be included in this study, individuals had to have followed for more than 2.5 years. And it's not really an attrition bias. That's maybe one we're a bit more familiar with. That comes from clinical trials when you've randomized folks into multiple groups. And if you have more people drop out of one group than another, you get worried about what's causing that. Might that bias your results? That's a little bit different here, but it's a similar idea. As you get worried, as you are losing people along the way, you start to be concerned that the folks who stuck in your trial and finished the study are not the same as the folks who dropped out. And maybe you're missing a lot of things here. The authors wrestle with that well in their discussion and say that's likely going to lead to an overrepresentation of the benefits of treatment here. It's hard to quantify that since we don't know what we don't know here, but something we certainly have to keep in mind. Okay, so coming back to this study here again in the methods, the patients, There were initially quite a few patients who had an initial visit during that time period, nearly 2,000 individuals, but over 1,000 of them were excluded because they had not had follow-up within that 6 to 12 month period after that initial visit. And additionally, another nearly 500 individuals were excluded due to some of those other criteria that we walked through. So of that initial nearly 2,000 individuals, about a quarter of those, 428, were able to be included in the final analysis. So I think really highlights here, this is a subset, and this is a relatively small subset, only about 25% or so. Interventions that were used in this center. So first of all, there was lifestyle modification counseling provided by obesity medicine physicians and nurse practitioners. Several things were fairly consistent. So they were counseled on a low glycemic index approach. That's what was recommended as a diet. The specific caloric targets were not provided to individuals, to patients here. Intermittent fasting, there were varied options of that. So that was offered, not always used, but was an option for providers to recommend that. And then also general physical activity and exercise recommendations were provided. There were also RD visits, so registered dietitian visits were offered. And then, of course, as we're looking at here, different anti-obesity medications were offered. A few details we thought we'd include here in this section. It shows up in the results, but just to give you a sense of what this actually ended up looking like. So as far as the visits go, there was a average duration of 4.4 years. That worked out to average number of provider visits of 15 over that time period. RD visits were much fewer than that, only 2 on average, and then again on average 2 anti-obesity medications. We'll come back to all that in the results, but it helps you understand what that actually looked like in practice here. So we want to stop and pull Jamie back in here. So Jamie, help us understand this. So we just walked through at this center at Cornell in New York City what happens, but give us a sense. You understand the landscape of obesity medicine, at least here in the United States. Is this a fairly standard approach, or were these folks doing things that were maybe a bit atypical compared to other centers that we would need to keep in mind as we thought about potentially applying these results to our own practice elsewhere?
I'm going to start with a politician's answer. There's no such thing as a standard approach in obesity medicine. And I think that's important for the audience to understand. This is a highly specialized weight management center at a large academic institution where there are resources and expertise across a variety of kind of obesity subtypes and also comorbidities or complications within there. I think if we kind of look at some broad categories with regards to kind of duration of follow-up and also kind of frequency of visits, I would say what we see here is patients following up probably every kind of 8 to 12 weeks for about 4 years in a specialized kind of weight center, which is kind of what we aspire to. But there are high levels of attrition for many people who seek obesity care due to a variety of reasons. People may not come back because they've done really well, at least for now. People may not come back because they're not doing well, or they may have experienced, unfortunately, stigmatizing experiences, medication side effects, a whole host of things. The number of dietitian visits, its average is like 2 in 4.4 years average follow-up. Now, it's hard to know how those sync up, but many of us will look at nutrition interventions as one of kind of the tenets of health behaviors that support both kind of weight reduction and maintenance of weight. So that seems low given that this is a specialized center. However, in the real world, when people are being prescribed or prescribing anti-obesity medications, this is likely happening in a primary care office where there are no registered dietitians present, where patients may have to go and seek out specific kind of RD support, if possible, if they can find them, or if it's even covered by their insurance. So I think there are a lot of different kind of factors we could look at this and go, well, is this typical or not? But I think we need to acknowledge that there's a lot of heterogeneity in terms of practice settings for this. And I think the take home should be is that patient engagement as measured by kind of regular follow-up is important. Seeing your patients back is important. Getting patients the RD and nutrition specialist, both kind of intake history and education and individualized support is also important. So I think we need to kind of look at how we can support that more consistently in our day-to-day practices for ourselves.
We're going to wrap up the methodology with the outcomes, and Jamie, will come back to you here shortly, and thinking about the primary outcome that the authors use. And they describe that as the total percentage weight loss from the initial visit to the final visit. Jamie, you alluded to earlier on in the introduction that there's some argument maybe about what is clinically meaningful weight loss, but give us a sense of, well, how do we even measure that in the first place? Sometimes general endocrinologists and other folks like me get a little bit lost as we see the different ways that weight loss can be described. Has there been some consensus, or what is the best way to think about reporting weight loss from any sort of an intervention in a way that's consistent and allows us to compare study to study?
Most weight loss studies now are studies where weight reduction or weight change is a primary outcome will report mean weight change. I think looking at categorical weight loss is maybe a more meaningful way. We talked about kind of clinically significant cut points in weight reduction. It can be helpful for us to contextualize, well, what proportion of patients will achieve, say, a 10, 15, or 20% weight reduction. That really helps to guide the conversations with the patient, but then also expectations of the clinician, because you may see average weight reduction, for example, with semaglutide 2.4 of around 15%, a third of people lose 20% or more. So it's about how do we really contextualize the mean result into something that we can have a discussion with our patients, especially when they're giving us what their goals are.
And likely for that exact reason, the authors include several secondary outcomes, including categorical weight loss, just like Jamie alluded to, 5%, 10%, 15, 20% weight loss. Also, the nadir, BMI, the time it took to reach that, the percent weight regain from that nadir, and then finally the percent of patients who maintained a weight loss, which the authors here described as a regain of 3% or less from that nadir weight. Okay, so there's our methodology. We will think about this more as we go through the results and then finally the discussion, but I'm going to hand things back off to Andrew at this point. He's going to walk us through a lot of the numbers that the authors present here in their results.
I think it bears repeating, talking about the population we're looking at. So again, recall that there were about 2,000 patients that had that initial visit. Half of them did not have a qualifying follow-up visit. So that brings us down to about 1,000. And then half of those remaining 1,000 were excluded because of the criteria as discussed. So of the 428 patients that remain, the average age was 51. 73% were women. The average BMI was in the obesity class 2 category, so that's 35.5. And then when we look at the BMI breakdown, we see that the majority of patients were in obesity class 1 and 2, with 35% in class 1. And just as a reminder, we can think of overweight as being body mass index of 25 to 29.9, obesity class 1 of 30 to 34.9, class 2, 35 to 39.9, and class 3 would be 40 or above. Then we see on the bookends, we have 20% of the patients, 19% actually, in the overweight category, and 20% of patients in obesity class 3. In terms of comorbidities, we see that patients had an average of 2, with prediabetes being the most prevalent with 35.5%. Psychiatric disease, which was seemingly a catch-all term, a third of the patients were labeled as having that. 31% with high blood pressure, 31% with dyslipidemia, and 16% with type 2 diabetes. Looking at the racial composition of the population, interestingly, almost 56% of the participants declined to answer racial questions. They were 34% white, 4% Black, under 1% Asian, and 3.4% other. So, Jamie, with this breakdown of the demographics, do you have any comments on the inclusion or exclusion and the demographics?
I think this is fairly representative of what we see in clinical practice in obesity medicine. The vast majority of patients seeking care are women who tend to be kind of in our clinic group, it's around 45 is the average age of the patient we're seeing, and our patient population is 80 to 85% women. So I think this kind of tracks with that. When we look or talk about the kind of inclusion-exclusion criteria, or we kind of look at the patient flow diagram as to why patients were kind of excluded from their analysis from their patient population, I think there are kind of a few things there. The biggest category is that there wasn't enough follow-up or wasn't follow-up more than 2 years However, 12 people were excluded because of weight loss surgery during this time period. And I think it's important to know that weight loss surgery or bariatric metabolic surgery, similar to anti-obesity medications, is greatly underutilized in people with obesity and is very effective for weight reduction, treating disease. And so that was one factor. And then also starting BMI less than 25 was one of the exclusion criteria also. We do see people in our clinics all the time who have BMI less than 25 who may warrant treatment for excess adiposity or excess weight. And so it's how do we meet the needs of those patients, but then how do we analyze data in the context of patients who may not look like on paper they meet criteria for medical management for their weight.
Looking at the weight loss outcomes and the overall results, we do see that the duration of participants was 4.4 years. The mean weight loss, total body weight loss, was 10.4%. And that translated to a mean BMI change from 35.5 to 31.7. And then we see this parsing out in terms of the categorical weight loss percentages, that 71% of these participants lost at least 5% of their weight. And then 48% lost at least 10% of their weight, 30%, 15% of their weight, and 17% of participants lost at least 20% of their weight. The mean maximal weight loss was 15.8%. And the time to that maximal weight loss generally was about 2.5 years. And then the average weight regain from that nadir was 6.5%. And so in the way that they had defined weight loss maintenance, that was achieved by 40% of their patients. So Jamie, on first blush, what do you think about those results?
I was very excited when I saw this abstract being presented. I think it was Endocrine Society in Atlanta. When the abstract was presented for this paper, I was quite shocked at the magnitude of weight change that was seen with this. And I think it's important to get the message out that you can achieve this magnitude of weight loss with older generation anti-obesity medications and combination use of therapies. It's almost like we're in a GLP-1 or incretin or bust type environment where people think that if we can't get a hold of these, then why even bother? What this paper nicely shows is that through combinations of therapies, and I think we're going to talk about the number of medications and combinations a little bit later, you can achieve clinically significant magnitudes of weight loss, but also that it takes time. The time to maximal weight loss was 2.4 years. This is not something we can expect to see in 3 to 6 months. It's about how we combine therapies, how we individualize therapies to the point that we're seeing 20% weight reduction in almost 20% of people. That kind of bariatric surgery range weight loss in almost 1 in 5 patients. I think we need to kind of get the message out there that these things are possible, but it takes time and individualization in order to kind of squeeze all we can out of medications that, interestingly, may be more accessible to patients than newer, more expensive, more effective medications.
So that's a great dovetail to then talk about how did they actually use these medications and in what combinations, how many did they use? So what they found that overall for their patients is that the mean number that were trialed was 4.3. So a number of medications were tried. And the mean number at the final visit was just over 2. And the percentage taking 2 or more medications was 65% of these participants. So then we see patients maintaining at 10% or more loss. We see that there was 206 participants. And in this group, 92 unique med combinations had been used. So certainly showing the complexity of this real-world medication usage. Now, in terms of the types of medicines used, we see off-label use of metformin being the most prevalent medication used, and there was 88.3% usage with that. For topiramate is 44%, phentermine 42%, bupropion 29%, and the most common final visit regimen included metformin monotherapy, and that was 13% of the time. Metformin plus phentermine plus topiramate was 9%. Metformin plus lorcaserin, which is no longer available, and that was 5%, and metformin plus bupropion plus naltrexone was 4%. So, Jamie, talk to us about this medication usage, especially in the context, as you already alluded to, of the current prescribing environment.
I think the point you said where the group of 206 people who achieved 10% or greater weight loss, they saw 92 unique medication combinations. I can't do the statistics on that in my head with regards to kind of what that means in terms of what meds, but that's really kind of real world practice. And I think it speaks to kind of the ingenuity that you have to use. The mean number of trial meds was 4.3, which means that it's not that a patient comes and you have them on one med and then you add another one and go, well, sorry, this really didn't work for you. I think it's important to highlight as well. I think it was 16% of the study population had type 2 diabetes and 88.3% were on metformin or had tried metformin. So it's important to kind of note the need to use off-label medications in circumstances where you are combining therapies to be most effective. Topiramate is another example of kind of an off-label med. Those were the two most commonly used medications there, and neither of them are individually approved for treating obesity. Well, metformin isn't even in combination. So I think it speaks to what we do in the office every day to combine therapies to hopefully find a combination that works.
So as we're going through and trying to treat our patients, decide what treatment is best for them, some of the questions that we ask and that the paper asked would be, are there any kind of factors or predictors of those who are responders, those who lose at least 10% of their weight? So they started and looked at a univariable analysis, and they found that the factors that were associated or predictive of this 10% weight loss were a few. So they said a higher number of clinic visits, older age, higher initial body mass index, high blood pressure, a higher number of medications at the final visit. It's notable that they found that diabetes was neither a predictor of weight gain or weight loss. It was a neutral factor, which is interesting and we can talk about later. And then the meds at the final visit that seemed to be correlated with a 10% or greater weight loss were metformin, topiramate, bupropion, semaglutide, and naltrexone. So then they were analyzing multiple factors at once using a multivariable analysis. And after this analysis, the things that came out as predictors included a higher number of clinic visits, similar to the univariable analysis, and then certain medications, so metformin, topiramate, bupropion, and lorcaserin. So then they were looking at predictors just of total percentage weight change, and the factors they identified were higher number of clinic visits, initial BMI, hypothyroidism, which I found interesting, the medications metformin and topiramate, and then they found that PCOS seemed to be associated with gain. So, Jamie, I looked at this information that was provided and I struggle with how to interpret it, but I did want to hear what you thought about the data. Does it seem to make sense? Is this an important part of the study? Would you be looking at your patients differently if you see them with these different factors or thinking it's going to be predictive? Is there anything about that you find surprising? So with that barrage of questions, what are your thoughts?
I've got a lot of thoughts. I'm going to try to consolidate them in a time-efficient manner. What we see when we look at interventions for weight reduction, pharmacotherapy specifically, is that people with type 2 diabetes lose less weight for pharmacological intervention. And we know that from step 1 versus step 2, surmount 1 versus surmount 2 with recent kind of nutrient-stimulated hormone therapies. And I would imagine that this is kind of a similar case here. To your kind of difficult question about, well, PCOS, why is that associated with weight gain during this? It's kind of difficult to tease that out. You could kind of posit something like, well, insulin resistance and PCOS, or there can be challenges with regards to other medications that could be used in combination, be it hormonal contraception or other things that may be associated with weight change, perhaps mood disorder or other medications that are associated with PCOS as well. It's hard to tease it all out. When we look kind of in total, I think the important thing to highlight is that patient engagement touch points, including number of clinic visits, are important, which is why so many interventions that are focused in on healthy weight or diabetes prevention and weight reduction, be it DPP or other type models of IBT or intensive behavioral therapy for weight reduction, focus in on multiple touch points with patients, which can be clinically difficult to achieve depending on the structure of your office and your health system and what resources you have. I think as much as we would love to be able to see every patient every other week or once a month, that's really not a reality for most of us, and how we then create touch points that can include staff within our clinics, such as registered dietitians, if we have access to them, if we have kind of group or shared medical appointments for patients with similar disease states, such as obesity or type 2 diabetes, to increase that touch point and engagement, or other online or virtual type platforms that can increase the way in which patients can troubleshoot some of the issues they may be experiencing, find support and engagement from their peers, or to get additional support when things aren't going as expected or anticipated. I think this highlights some real world examples of kind of what's there. And the number of medications also correlate with the number of weight loss. Anti-obesity medications are effective. For some, we just need to find the right balance and right number, which can facilitate the changes that we need to see to support better health and weight.
We mentioned before, and we'll continue to mention, that this isn't all about weight, of course. It is about health. And so they did report some metabolic factors and the impact of the intervention on them. And so we did see that for the group overall, there was an A1C improvement from 6.3 down to 5.9. And for those who were identified with type 2 diabetes, their A1C decreased from 7.3 to 6.6. And in blood pressure, we see an improvement of almost 3 millimeters mercury of systolic blood pressure and 1 for diastolic blood pressure. So that's the summary of the results. I'll turn it back to Chase for the discussion.
Andrew has given us a nice overview of a lot of the data here, and Jamie's given us his thoughts along the way. But we'll think about a few other things as we wrap up. So first of all, to quote the authors and how they summarize their findings. So they say, in this retrospective observational study of 428 individuals with overweight or obesity, patients maintained a clinically significant weight loss of 10.4% at a mean follow-up of 4.4 years. And this is the first and only study to report real-world weight loss outcomes beyond 4 years in a population treated with obesity polypharmacotherapy. A few other points that the authors make here. So whereas they try to compare their data to other data that's out there, they say it's very difficult because they don't really have any comparable studies, primarily because of how long their study went. That hasn't really been done before. Though they do point out that compared to other trials that are out there, other studies that are out there, that 10% weight loss at 2 years is fairly similar. And it does suggest that that in these studies that 10% does tend to occur by 2 years. And then there's maintenance afterwards for these individuals. The authors point out that, as Jamie and Andrew have both talked about already, that these results really show, they illustrate the need for highly personalized obesity care, and that it's a very heterogeneous disease. And additionally, as we've talked about already, they point out that polypharmacy is quite common in this real world usage, and that can be compared to other metabolic diseases. And that while expert opinion might recommend such an approach, it hasn't quite made its way into some of the guidelines that are out there. We've talked about this already, that there are some potential barriers to prescribing some of the newer medications. And in that context, these authors say, so we really shouldn't be viewing some of these older medications as obsolete. And Jamie, I did want to come back to you to give us some thoughts, particularly around metformin. I think there's variability as clinicians and how we think about metformin. You talked about we use it for lots of different reasons. Sometimes we tend to think of it as just a weight neutral medication. Sometimes we think of it more as a weight loss. So comparing what the authors found here to other studies that are out there, how would you suggest that we think about metformin, and did what the authors find, does that fit with the rest of the literature?
I think many of the times when we use metformin as endocrinologists, we're using it in people who have established diabetes or kind of a prediabetes or states that are associated with an attenuation of weight reduction. So we may think, hey, this is not something that really supports weight loss in a way that you see in this study. That being said, much of this is a combination therapy. So it's not that metformin is being used by itself. There was a minority of patients who had metformin monotherapy at their final visit. But the average patient saw, I think, more than 4 different medication combinations. So I think there's definitely a role for metformin, which is a safe and effective and reasonably well-tolerated medication. But importantly, it's also accessible. And so I think for many people, it's about kind of weighing up the costs and benefits and potential side effects and looking at what treatments are available to them.
The authors did want to point out an unusual finding. We've talked about a few already, particularly around the association with PCOS, but this one was around the GLP-1 receptor agonists that were used here. So not only was the use of such an agent not associated with more likely weight loss, but it was actually associated with a lower odds of achieving that 10% or greater weight loss. The authors speculate here that this is likely because this was early in the use of these agents for weight loss in particular, and that likely back at this time is that those medications were really reserved for what they call treatment-resistant obesity. It was not a first-line agent. It was reserved for those individuals who were struggling to lose weight. And so for that reason, that may actually be more of a confounding by indication if you wanted to think about it that way. Another point that the authors make, the final one that we'll highlight here, is that they point out, as Jamie talked about already, is that a greater number of follow-up visits was associated with an achievement of a 10% weight loss or greater. And the authors connect that to ideas around patient adherence and outcomes that you might see there. I'll editorialize here that may very well be the case. We would also need to be careful in thinking about that. That could easily be a confounder. I think a patient's ability, however you wanted to think about whatever the cause might be, but them being able to come to appointments and do so regularly, that is very likely to be associated with other things, whether they be resource dependent or behavior dependent, a lot of different connections you could make, but ones that would potentially be a real driver as far as weight loss goes. So I think we would want to be careful about just automatically saying, which the authors don't, but we want to be careful about just automatically jumping to, well, if we can just get our patients to come to visits more often, that would likely lead to more weight loss. May be associated, but something that have to be thought through carefully. Okay, to wrap up things here, we're going to think through the author's limitations. I mentioned earlier, I think the authors did a great job here, but they point out specifically they don't have a control group here. So initially, when you're just lumping everybody together, that's kind of that case series idea, is they're just putting everybody together. Everybody was treated the same. Specifically, we don't have a group that was treated without medications and with just the lifestyle interventions. So this allows a few different things to show up. So we don't know the impact of just lifestyle intervention alone as done in this center. And this is also how and why confounders can show up. The authors point out that their experience is that of a single tertiary academic weight management center. We talked about that being similar to how a referral bias works, but meaning their population may not be the same as everybody else's population. And also what they do may be different. Jamie walked us through already. There isn't really a standard of care for many of these sort of things. So we have to be cautious about applying these results to other groups. Another limitation the authors point out is that they don't have as much granularity around data with that lifestyle intervention. And so we're unable to discuss that. And then finally, another really important one that we talked about is that the authors described their analysis as that as a completers analysis. So that was that idea of they only looked at individuals who followed long term, and that is likely to introduce an overestimation. Jamie talked about actually, depending on how you think about it, could be an overestimation or an underestimation of the treatment effect, but likely, as these sort of studies tend to show, likely overestimates the effect here. So finally, as the authors conclude their write-up, they summarize it. I describe it potentially more as an implication, but I'll quote them again here, and then we'll give our thoughts on this. Is they say, obesity management should follow the same treatment principles as any other chronic disease. Consistent follow-up, polypharmacotherapy when indicated, and individualized care. So we're going to think about how this might affect the care that we provide or move the field forward here. But before we do that, let's just think about the results overall. Andrew, let's start with you. Just what is your sense about the quality of this report as presented by the authors here?
This is encouraging to provide people with more evidence that some of the training that they used to treat other chronic diseases can be applied and that people can learn to become comfortable with multiple medications. And so I do like the real world aspect of this study and showing that it takes trial and error, it takes persistence, it takes showing up for our patients and then showing up for us. So I do think overall there's a lot of valuable information that can be obtained. But there is stuff that we'd like to know, like what kind of methodology did they use to change their treatment options? How did they escalate, de-escalate? And it would be interesting to know something such as, did early treatment predict later outcomes, as we've seen in knee replacement studies, as we've seen in bariatric surgery? So there are some more granularity that could be used to other people to think about their own practices.
Good. Jamie, we'll wrap things up with you. Why don't you give us a couple different thoughts of quality of the report overall, but then also wrestle like Andrew did with the idea of, should this change our practice? Should this confirm what we're doing? Should this help move us in one direction or another, particularly as medication options so rapidly evolve? But why don't you finish us up with giving us your thoughts on those two areas?
Sure. From a quality perspective, the authors are very forthcoming with regards to the limitations. The study is real world. It's very real world, but that's where we practice. And I think it's important to acknowledge that there are limitations in the data. But what this shows is that you can help people to achieve clinically significant weight reduction through combinations of therapies, long-term follow-up, and what seems like trial and error in the most individualized and educated way possible. When it comes to kind of clinical practice and kind of what I would take home from this paper is that you can achieve clinically significant weight reduction with older categories of medications. And I think it's important to treat obesity. It's too easy to become discouraged when we try a prior authorization or send a prescription for a new incretin-based therapy and it gets rejected, because we know what the evidence says will be the most likely to get our patients to a healthier weight or a healthier state. However, we should not stop there. We should start medication therapies as adjuncts to lifestyle, which can be helpful for our patients. And this supports that combination therapies can be very helpful to get our patients where they need to be.
And with that, I would like to thank Andrew Crafson and Jamie Almendoz for joining me for this month's edition of Endocrine Feedback Loop. I learned a lot and know that you all did as well. Please join us again next month. And now you're in the loop. This has been Endocrine Feedback Loop. Endocrine Feedback Loop is brought to you as a members-only benefit of the Endocrine Society, with production oversight by Brandy Brown and Andrew Harmon. We would love to hear your feedback on this episode or the podcast itself. Please email us at podcast@endocrine.org.